Hi, everyone. Welcome to the Ask the Experts Q&A, and we have Dr. Massie with us today. We had everyone submit their questions since we weren't able to do our educational sessions this year, and we thank everyone for sending them in. So we'll get started. So I just wanted to let everyone know that the questions that came in for the vaccination questions around COVID and flu vaccinations are answered through another session that's already been done and is available on our website with Dr. Hans Katzberg. And he answers all your questions there. So if you don't see them in this Q&A, you can certainly go on and your questions will be answered there. So I'd like to introduce Dr. Rami Massie. He's a neurologist specialized in neuromuscular disorders in general and ALS and neuropathies in particular. He finished medical school and residency at McGill and did a 2-year fellowship at the Mayo Clinic in Rochester. I also want to note that he resides on our medical advisory board and he's been a phenomenal support for us and for our patients. Welcome, Dr. Massie.
Thanks a lot for the invitation and for the nice introduction, Donna. So I'm very happy to be here and to answer these questions. So let me start by moving the slides forward. We talked about the fact that the flu vaccine, the flu shots and other vaccine related questions will be answered through a different presentation. All right, so let's start. This is question 1. I occasionally hear anecdotal comments about CIDP patients experiencing autonomic nervous system problems. Do you know if there's any specific research and findings in this area? So yes, there's been a few studies looking at that. And during my fellowship, I also participated in one study looking at autonomic dysfunction in CIDP. In general, it's not very common in terms of symptoms of autonomic dysfunction. Less than 20% of patients report some symptoms, but I would say that when we test it rigorously, we find that there is very common presence of pseudomotor dysfunction, so sweating. So not surprisingly, when you have a neuropathy and you have nerve loss, it's not uncommon to have decreased or loss of sweating. So that's the most common autonomic dysfunction. There's also some cardiovagal dysfunction, meaning less reactivity of blood pressure during changes in position or other stimuli. But this is, again, subclinical, and it's not common that CIDP patients actually have autonomic symptoms. I think I stopped. Yeah, I skipped the first question. So I'm going back to the first question. I was diagnosed with multifocal motor neuropathy in 2010. I have pain and numbness. I have worsening numbness in my toes. I'm frequently told that MMN is not sensory, therefore pain and numbness are not symptoms of MMN. Also lots of fatigue. These symptoms seem to be common complaints of others with MMN. So the question is, are you able to explain the likely cause of these sensory symptoms and what should I do about them, if anything? So several reports have looked at the prevalence of sensory dysfunction in multifocal motor neuropathy. In theory, multifocal motor neuropathy with conduction block is a purely motor syndrome, but some patients do report some sensory symptoms when you look at when it is studied rigorously. People have also looked at sural nerve biopsies or at sensation of vibration in patients with MMN, and there seems to be some abnormalities in quite a few patients. So I don't think it's completely impossible. However, the caveat and the warning I would say is that you should always think of the possibility of something called motor CIDP as an alternative diagnosis to MMN with conduction block. So motor CIDP is a variant of CIDP where you have pure motor symptoms, so weakness, with very little sensory symptoms or dysfunction. But usually you do have some abnormalities on nerve conduction studies, and that's one of the main differentiating factors between the two. Another differentiating factors is that if you do have nerve hypertrophy, like if you image your MRI lumbar spine and you see a lot of nerve hypertrophy or enhancement, it's more likely to be CIDP than multifocal motor neuropathy. So Yes, it is possible to have mild sensory dysfunction in MMN, but also consider the possibility of a variant of CIDP. Next question. What can be done about lingering bifacial paralysis as a result of initial GBS whole body paralysis? That's the first part of the question. And there's a second question that we lumped together because they go together. Dr. Massie, I'm a GBS liaison in BC. One of the people in my group who has had GBS has recovered very well, is struggling with facial paralysis and some Bell's palsy. Her speech is affected because of this paralysis, and she would like to know what she can do, if anything, about this. Do you have any suggestions? So tough questions, I would say. I think that there isn't any definitive proven treatment to improve facial weakness post GBS or post other neuropathies, including Bell's palsy. So if you see ENT, some ENT will refer you to have some form of electrical stimulation to your facial nerves. So I've certainly seen several patients have that. It's not painful, but it's not definitely proven to help. Can it help? Maybe, but we don't have evidence that it does. So I'm not against it because I don't think it hurts, but it's not proven to help. Sometimes you have other dysfunctions related to the facial paralysis, and then we're better at treating those than treating the actual weakness. If you have, for instance, you know, a bit of drooping of your eye, that can sometimes be surgically corrected. Sometimes after severe nerve injury, the nerve regenerates, but the connection goes to the wrong place. So you get a phenomenon called synkinesis, where when you're smiling, for instance, you're smiling or you're eating, and then you start tearing up because the nerve that is supposed to go to your smiling muscle is actually going to your lacrimal glands by mistake. So this is called synkinesis. And if you do have that, sometimes Botox injections help with the synkinesis. I would say these are the main interventions. For the second part of the question, the patient was affected with speech dysfunction. Again, I think there's nothing to do to help the muscle itself, but speech therapy definitely can help. The speech therapists are very good at providing compensatory techniques for some speech dysfunction, and they can show you what kind of exercises and what kind of muscles you can activate to help compensate for your deficit. So I think that's definitely an option worth exploring. All right, next question. If a patient's CIDP is not responding to IVIG, sub-QIG in a combination with prednisone, what would be the next potential treatment journey? Well, there's a lot of different options. I think it depends a lot on the clinical presentation. I would say that there's 3 primary treatments for CIDP or first-line treatment: IVIG, cortisone, you know, whether it's oral prednisone, IV solimedrol, oral decadron. There's different forms of cortisone, but cortisone. And the third one would be plasmapheresis. So to be honest, in a case like this, the first thing I would do is, one, question the diagnosis. Are we sure that this is CIDP? And if we are, if the EMG is clearly typical and the whole clinical presentation is typical, the second question is, have we ruled out a refractory form of CIDP? And if the patient hasn't responded to IVIG, I think it's worth sending those new antibodies for Contactin 1 and neurofascin antibodies. Because those often do not respond to IVIG, although they do respond to prednisone and may require a different drug like Rituximab. The other thing I would do is make sure that the patient has received an appropriate IVIG treatment trial. So I always try patients for at least 3 months. If I'm not really sure, I sometimes extend it to 6 months. I make sure that I give a good dose, which is usually 1 gram per kilo. But sometimes if they haven't responded or they responded only partially after 3 months, and I'm sure it's CIDP, I increase the frequency of IVIG to once a week or once every 2 weeks. So we talked about doing the antibodies, we talked about increasing IVIG, and we talked about plasmapheresis. Then comes second-line treatments. If patient has responded partially but not completely, and if we want to try to wean down IVIG, sub-QIG, or prednisone, Some experts have added azathioprine or Imuran. I've tried that a few times and I've never had significant success, but that could be a good long-term option for patients who respond, but not 100%. Then come the bigger guns. So there's reports that rituximab, cyclophosphamide, or even bortezomib help in CIDP. I don't have any experience with bortezomib, but I've tried rituximab and cyclophosphamide, and I find them more aggressive therapies. It's pretty rare that I ever prescribe them because most patients with classic CIDP should respond to one of the 3 primary treatments. Next question. I'm relatively new diagnosed, 9 months, receiving IVIG, but also being followed for chronic back pain post 4 surgeries in a 3-year span. Question, can CIDP cause neuropathic pain? Well, the short answer is definitely CIDP can cause neuropathic pain. It is not common, but it's definitely possible. Most of the time, the neuropathic pain is distal at the level of the feet where you have the tingling and the sensory loss. I don't think it's completely impossible to have neuropathic pain in a radicular pattern coming from the back, but that's definitely less common. The other thing that's important to know is that CIDP can cause different patterns of pain because of the way you walk. You know, if you have a foot drop or if you have proximal weakness, that's going to completely alter your walking and your gait mechanics. And sometimes that can lead to worsening arthritis or disc disease in your back, which can worsen the pain. So CIDP can cause neuropathic pain, but you know, if it's really radicular coming from the back, like sciatica type pain, it's much less common, and I would make sure that it's not coming from the back itself. Humoral factors are involved in the pathogenesis of different neuropathies, such as GBS and CIDP. How do the antibodies affecting the peripheral nervous system pass through the blood-nerve barrier? So humoral factor means antibody-mediated inflammatory process. So the antibody passed through. So as you know, there's a barrier that separates the blood vessels from the nerve, and that barrier is easily broken whenever there's inflammation. So the inflammatory cells, other than the ones that secrete antibodies, will secrete some factors that will cause inflammation that can make the blood-nerve barrier leaky. So any inflammatory process will lead to breakdown of that blood-nerve barrier. Is it possible or wise to have such a surgery, ankle replacement due to osteoarthritis, then extensive rehab, while still in recovery from GBS? I'm currently 8.5 months out from onset of GBS. I'm actually terrified of the idea of triggering GBS or worse if I do. So I would say that it is unlikely that the surgery will trigger GBS again. So I think that's my first reassuring statement. However, in general, I would say that it's better to complete your rehab and reach a plateau before considering further surgeries in general. So I think if you're improving slowly from the GBS and you're still improving despite being 8.5 months post the event, and that's definitely possible. If you're still finding that you're better today compared to 6 weeks ago through the rehab, I would continue the rehab until I reach a plateau and then consider the surgery after. Now, the only thing is that if you feel that the surgery the underlying problem, like the extensive ankle arthritis, is preventing you from participating in rehab, then it may be reasonable to get the surgery before. So there's no direct, easy answer. I think it depends on each situation. But if the ankle problem is preventing you from participating in rehab, it's worth considering during surgery earlier. But again, the main message is that the surgery will not worsen GBS, but it's usually better to complete rehab before passing to another stressful event. Is it possible that I have 2 different conditions? When I talk with my brothers, they have the same feeling in their feet as I have, but they don't have CIDP. So this is actually my patient. I know her very well. I think we can discuss this in person, but I would say that usually CIDP is not familial. So if 2 brothers have neuropathies, you have to wonder about an inherited neuropathy in the family. in which case, yes, it is possible to have two different conditions, but I don't want to generalize. I think we'll talk about it in person specifically. How do you know if you are in remission? I've heard several people say it is when you aren't on any meds, but how do you know when to go off of them? Yeah, I think this is a very good question with which we struggle every day in clinic when we see people who are doing well. In general, I think that some CIDP patients need chronic therapy, whether it's IVIG, prednisone, or plasmapheresis, whereas some CIDP patients do very well and go into remission after an initial period lasting from a few months to a couple of years where they're more active. And we know that because when we looked at CIDP patients who participated in clinical trials where they had to stop their medication because of the clinical trial before going on to another medication, there's a surprising proportion of patients who actually didn't relapse even after stopping IVIG or plasmapheresis, whereas we expected them to relapse because they've been on these medication for several years. So we know that it is possible to go into remission, and that there's a lot of patients who actually are receiving IVIG who may do well after we stop it. So how do we identify them? Well, there's no magic trick. There's a few things, if you don't have wearing off, meaning that if you don't feel weaker before the next IVIG dose, then that's a good sign. And that's usually a trigger for us to extend the IVIG, to decrease the IVIG frequency by extending the time between two IVIG infusions. So often when somebody's doing well, I decrease the frequency from every 3 weeks to every 4 weeks, and sometimes to every 6 weeks. And if they're doing very well with IVIG once every 4 weeks, or once every 6 weeks, and relatively small dose, then it's very reasonable to stop and see if they go into remission, meaning that they don't worsen after stopping it. Certainly if they worsen, the trick is to retreat them early enough to make sure that they don't worsen too much. So it is very reasonable to try stopping therapy on a regular basis, or at least extending it progressively and decreasing the frequency and eventually the dosage to see that if you really need it. Can you explain the science behind why steroids are contraindicated for MMN patients? The short answer is no, I cannot. Dr. Larue provided an interesting theory where she mentioned that steroids do increase neutrophils in the bloods. So whether that can worsen MMN is possible. I have to admit that whereas I understand there are reports of patients worsening with steroids, I've never seen it myself. I'm not convinced that this is a very common occurrence. And I even wonder whether that worsening with steroids isn't actually related to simply disease progression without appropriate treatment, meaning steroids aren't working and the disease is worsening, rather than really the steroids causing the worsening. But I don't know why. We know that in Guillain-Barré syndrome, steroids don't work. There's one small study that suggests that it may worsen GBS, but I think most people agree that it doesn't really worsen GBS, it just doesn't work. And I think it has to do with timing of steroids and how rapidly effective it is compared to the rapidity of the antibody attack in GBS. But I don't have a similar theory. I'm not sure why it doesn't work in MMN. I had GBS in 1990, treated with plasma exchange. Since then, I've had chronic muscle stiffness, body aching, electrical-like shocks in my feet, sensitive skin, and orthostatic hypotension. I've since been diagnosed with fibromyalgia. Could my current condition be related to GBS? I'm unsure if fibromyalgia is the correct diagnosis, as typical treatments provide limited relief. So definitely, I think that we see and we can have significant neuropathic pain and even, muscle stiffness, body aching, electrical-like shocks post-GBS. So if the timing is as you say, meaning, you were asymptomatic, you had GBS, you developed these symptoms during the GBS event and it's persisted since then, I think it's definitely possible it is from GBS. You know, GBS gives you a nerve injury, and whenever the nerve is injured, it doesn't always recover 100%, and it can leave residual symptoms. So I wouldn't disregard these symptoms if the timing is correct, meaning, you know, you developed them during your GBS event and they've been persisting since then. You know, fibromyalgia is a difficult diagnosis. It's a diagnosis, it's a syndrome, and it's a diagnosis based on excluding other causes. And you may not have any other residual, any other active neuropathy at the present time from GBS, meaning you have recovered quite well, but maybe at the molecular level, you haven't fully recovered. So I don't think it's impossible that it is related to the GBS. But, sorry, just to come back, but it's still the same treatment usually. There's no, the fact that it is related to GBS doesn't change anything to the treatment. So we can treat the electrical shocks with neuropathic pain medication. The muscle stiffness, the body aching is also treated with usually some form of exercise, even though I understand it's worse in your case, with pain medication, and the orthostatic hypotension has treatment for it as well. So it's still a symptomatic treatment, still symptomatic treatment. Why does my neuropathy, I have CIDP, seem to be worse at the beginning of my period? I experience more weakness, numbness, and definitely elevated pain levels in abdomen and legs, sometimes unbearable. Well, I think it's not unusual to have worsening of any pain syndrome during the menstrual cycle. Certainly we see it with migraine, and we think it's related to the hormonal variation, obviously. And any chronic pain disorder often does have changes with the menstrual cycle. And at the molecular level, I can't tell you that I understand it completely, but there's definitely hormonal receptors next to pain receptors that can modulate them. So I don't think it's impossible. Is it normal practice to monitor for neutropenia caused by high-dose IVIG or for hemolysis in new patient? Has this been seen in practice with sub-Q IG? So there's no definite guidelines about how frequently we have to monitor patients on IVIG, but most of us will do some form of monitoring. I can't say I would screen systemically every patient for subclinical hemolysis. So if your hemoglobin isn't falling down, I wouldn't check for more tests for hemolysis. But I would say that most of my patients who receive IVIG do get some form of monitoring. So I usually do a blood count on a regular basis. And I'm saying vague on purpose because this varies. Some people do it every 3 months, twice a year, once a year. But I think it's reasonable to do some form of regular CBC monitoring when you're on IVIG without necessarily looking for subclinical hemolysis. Has this been seen in practice with sub-Q IG? I haven't seen hemolysis with sub-Q IG. It shouldn't interact in theory. So I think sub-Q IG would be a good option for somebody who has had previous hemolysis. Please explain rebound antibodies when Rituximab would be used. What is the ideal IgG trough with IVIG to achieve therapeutic level of IgG to compete with autoantibodies? How is dose frequency determined and why so much variation? Well, there's several questions here. Let's start with the second part. So there's no ideal IgG trough with IVIG. So that's very clear. And the only thing about IgG levels and IVIG is that we know that people who have a brisker IgG response after IVIG is given for Guillain-Barré syndrome, meaning that if their IgG level increase more quickly after you give them IVIG for GBS, those people do better. That's the only correlation we have. But there's no correlation about how low the IgG levels have to go between doses. There really isn't. We know that the half-life of IVIG or the turnaround time is about 3 weeks. So usually at 3 weeks, you should probably give another dose. That's typically, but that's just in terms of antibody level in the blood. So the typical frequency would be every 3 weeks. But like I said, that's for your typical levels in the blood. It doesn't mean that you need those same amount of level to have an effect. So maybe just if you have some effect is achieved at very low level, and that's why some patients require it only every 4 weeks or 6 weeks. And maybe other patients consume these immunoglobulins more frequently, and then you need more frequent dosing. So the only way to determine it is clinically. Based on the ICE trial, ICE trial is one of the biggest IVIG trial we've had. Our typical loading dose is 2 grams per kilo, followed by 1 gram per kilo every 3 weeks. And that's what we usually do. And then we often modulate based on other variables. So if they're doing well on every 3 weeks, then like I said previously, I decrease the frequency. If they're not doing well, I sometimes increase the frequency or the dose. And if they're admitted in hospital and very severely affected, I do usually give the 2 grams per kilo as recommended, but then I may decide to dose them once a week or once every 2 weeks rather than once every 3 weeks, just for the first month, for instance, to make sure that I have a more frequent effect when they're more severely affected. So that's for the second part of the question. Now, the first part of the question about rebound antibody with rituximab, there's no real rebound phenomenon. So as you know, rituximab is a molecule, it's an antibody, it's a monoclonal antibody that targets CD20. CD20 is a protein that is located at the surface of the cell, and it is located in those cells that are precursors for plasma cells, and the plasma cells are the cell that secrete the antibody. So basically, by attacking the CD20, the rituximab will deplete all the cells that eventually will become antibody-producing cells. So once the effect of rituximab stops, then those cells will regenerate. And as the cells are coming back and producing antibodies again, then you have reproduction of antibody. But it's not in excess compared to previously. There's no real rebound. It's just coming back. And in order to know how frequently we have to dose rituximab, classically, we dose it every 6 months for the first year or 2. And then after that, we can measure specifically those CD20 or CD19 levels in the blood. And some people advocate to re-give rituximab only once the CD19 and 20 start going up again, and not necessarily on a fixed regimen. So you dose those proteins every 3 months, and once you see signs that they're coming back, then you give another dose of rituximab. And I sometimes do that as I try to taper somebody from the rituximab. For antibiotics under fluoroquinolone, Cipro, Levaquin, I have seen there are a number of class action lawsuits, sorry, with regards to this family of antibiotics. One of the side effects is peripheral nerve damage. Levaquin is the antibiotic that I was on just prior to being diagnosed with GBS. I remember having burning, prickling like blisters on my thighs and torso. The pharmacist recommended that if the issue continued to come back in a couple of days. Just wondering what the expert know about this antibiotic. Sorry. Well, we do know that fluoroquinolones are associated with peripheral neuropathy. Often they're associated with length-dependent, slowly progressive toxic neuropathy in the feet. And they're often, that neuropathy is often related to the amount of fluoroquinolones you've taken. So, sorry, if you've been on fluoroquinolones for 3 months for a chronic infection, you're more likely to have to develop neuropathy than if you've just taken 1 dose. Now, there's also some reports of increased rates of GBS on those antibiotics compared to other antibiotics and compared to the not taking antibiotics. So there may be a link. Obviously, very difficult to prove, but there may be a link. That's all I can tell you. CIDP and MMN patients can test positive for NF155 and NF140/186. Do GBS patients have this possibility as well? Yes. We don't routinely test for these antibodies in GBS patients, but I recently saw an article suggesting that we should. And actually, when GBS patients test positive for this antibody, it often suggests that there's a likelihood they will become or be CIDP. I think that's a follow-up question later on. So some CIDP present acutely, and then we call it GBS because it looks like GBS, but in reality, it's just an acute presentation of CIDP. So when you have positivity for these antibodies, that may suggest that your acute presentation that looks like GBS may become a CIDP. Could NF155 and NF140/186, Contactin 1 and Contactin associated protein 1 help you diagnose and treat your patients? Do you test your patients for these? Yes, I think Dr. White gave a presentation on this, Chris White, in the past. So definitely, I think these are called paranodal protein because they're present next to the node of Ranvier, which is an area of the nerve where there's no myelin. And the presence of these antibodies will can help sometimes confirm the diagnosis, and otherwise will tell you that you have a subset of CIDP that will not respond to typical IVIG treatment. So however, so these antibodies have gained a lot of notoriety lately, which is great. But in the same time, we have to tell patients that these are very, very, very rare conditions and antibodies, and usually less than 5% of all your CIDP patients are will have those antibodies. For instance, when the publication came up, I decided to test all the patients with CIDP in our hospital for these antibodies, and we sent them to Spain, actually, where they described these antibodies first, and none of them had them. So just to remind you how rare they are. Do I test them? So I've tested all of the patients that I had at the beginning, and then now do I test them routinely? Well, I think they're mainly useful to be tested in patients who don't respond to IVIG or other conventional treatment. So if you do have a CIDP patient who's not responding well, you should absolutely test for them. If you have chronic CIDP patients and you've been on treatment with IVIG, it's working, you're doing well, I don't think there's any point testing for them. And some neurologists advocate testing for any new patients with CIDP. I can't say that I do that, but I think it's not unreasonable. Alternatively, you can see if they respond to IVIG and then test them only if they don't respond. So, but it's not unreasonable to test new patients. For patients that were diagnosed with GBS and then shortly thereafter are diagnosed with CIDP with NF155, they really have GBS first, or was it always CIDP? So I answered that earlier. So I think clearly that this was an acute onset CIDP presentation, and we call it GBS because we have no true mean to differentiate the two when the patient first comes. And like I said, the presence of these antibodies when the patient comes with GBS can help you guide, can guide you towards saying, yes, this is probably an acute presentation of CIDP, although, you know, it's not 100%. I would say that less than 5%, maybe, less than 10% for sure, and maybe 5% of CIDP patients present with acute onset and are called GBS first before we change the diagnosis and call them CIDP once we follow them. I think Dr. Dion from Quebec City had a nice article trying to find clues to acute onset CIDP versus GBS. And usually the acute onset CIDP have less need of intubation and less autonomic dysfunction. And usually they're usually a little bit milder than the GBS cases. But, you know, that's statistically, in an individual patient, it's hard to tell. How do you feel stress during the strange time affects your patients? What recommendation do you make regarding this? Well, I often tell patients that, you know, stress is everywhere in life. You can't avoid it completely. Of course, you can change your lifestyle and, you know, decrease the amount of job, and, you know, you can do changes to lessen stress, but, you know, it's going to be everywhere. And actually some people do better under stress and strive under stress. Now, a lot of stress is not good for CIDP, but it's also not good for any chronic condition. You know, stress can make you feel more pain, can worsen depression. It's a problem in all medical conditions, whether it's headache, in all neurological conditions, we see that stress worsens somebody's symptoms. So like I said, we can't completely avoid it. So what recommendation do I make? People don't often ask me for recommendations, but I can tell you in general, recommendations are well known. I think that doing something you enjoy is important. There's a lot of relaxation techniques that are described, yoga, some form of therapy to help deal with stress. I think doing a sport in general, not necessarily yoga, is usually beneficial, and that those endorphins help you with stress. So you can't get rid of it. It's just a matter of knowing how to manage it and perform and be well despite the stress. What are your recommendations for CIDP patients with leg cramps and twitching? So the big expert on cramps is Dr. Hans Katzberg in Toronto, and he's published quite a bit on that. You're right that cramps are very common in neuropathic conditions. We usually, I personally try non-medical ways to begin with. I tell patients to take over-the-counter magnesium. Sometimes it helps. I also tell patients to try tonic water because it contains minimal amount of quinine, and sometimes that helps as well. Otherwise, we know that stretching exercises definitely do help prevent cramps, not only treat them, but prevent them. Otherwise, there's a ton of medications people have tried for cramps, and people have tried baclofen, gabapentin, pregabalin, and none of them work perfectly, and all of them may have potential side effects, but some people try that. And finally, I think one of the best treatment for cramps is probably quinine, although there's, as you know, a black box warning saying that it can cause some cardiac problems and some hematological problems. I do prescribe quinine sometimes, more frequently in ALS patient, but also in neuropathy patient. After discussing the potential black box warning and the potential side effects. I have to say that these side effects were seen with very high dose of quinine treatments for malaria, and we don't see these side effects usually with small doses of quinine that we prescribe for leg cramps. But you have to be safe, and you have to discuss these potential side effects before prescribing it. What do you think the number of patients that are diagnosed with GBS and then later go on to be diagnosed with CIDP? Is there no connections? So I think we've talked about this. Less than 10%, probably around 5%. Yeah. Is there a diet that you recommend to your patients? The short answer is no. So there's a lot of recommendations to be done about avoiding toxic elements for your neuropathy, and the most toxic of them that you can avoid is probably alcohol. We have a discussion about avoiding some toxic medications, but alcohol in high doses is clearly toxic to nerves. Some people believe it's toxic through vitamin deficiencies, but I think it's also directly toxic by itself. So I don't tell patients to stop drinking completely, but to make sure that they don't abuse any alcohol. In terms of diet by itself, I think that it's very common sense stuff. Healthy, balanced diet that gives you most of your required vitamins. We don't recommend patients lose weight or gain weight in general, unless you're obviously overweight or underweight. But I think gaining weight makes it harder to walk when you're weak, and rapid weight loss is also not recommended when you're trying to battle a nerve problem. So no specific diet. It's a lot of common sense, really. Does having CIDP make you more susceptible to getting cancer? No. Some medications like MMN can increase your risk of cancer, especially skin cancer. There's also reports of demyelinating neuropathies that look like CIDP but that are actually paraneoplastic. But CIDP does not increase your risk of cancer. What recommendation do you give patients regarding pain control other than medications? So I think the stuff I talked about earlier about, so stretching for sure can help pain if it's coming from cramping or increased tone. The recommendations I talked about earlier for stress control can help pain as well. So, meditation, yoga, some form of stretching exercises, these are all good for pain. Making sure that you treat whatever co-occurring depression or mood disorder is important because they feed into each other. So, the more pain you have, the more depressed you'll be, and the more depressed you are, the more pain you will feel. So I think it's also important to treat the associated pain disorders. Is foot drop typically the first noticeable symptom when MMN affects the legs? I have MMN in my arms and hands, but haven't had my legs tested in many years. I have arthritis in my knees, and my physiotherapist noticed a lot of wasting in the vastus medialis of my right leg. Wondering if it would be due to arthritis or MMN. So you're right that foot drop or ankle dorsiflexion weakness is probably the most common leg symptoms in MMN. Most multifocal motor neuropathy patients have hand weakness asymmetrically with atrophy, and that's the most common presentation. Not everybody has leg weakness. Actually, a lot of people do not have any leg weakness at all, but a foot drop or ankle dorsiflexion weakness is probably the most common manifestation. You can have knee extension weakness and vastus medialis atrophy from MMN. I don't think that's impossible. And arthritis in the knees would give you atrophy only by disuse, meaning if you do not use that knee at all or much less compared to the other side. So I can't answer your specific question, but both are possible. I think we're done already. That's fantastic. So Dr. Larue is doing the French version. We might not correlate 100%, but it should be close enough. We discussed before doing the session. And otherwise, I thank you for listening to me, and good luck with your disease.
Thank you, Dr. Massie. That was just wonderful. Nancy, I'll give this over to you.
Great. Thank you, Dr. Massie. My name is Nancy Edwards, and I'm the Outreach and Events Program Manager with the Foundation. I'd like to say a quick note to the patients and caregivers to please ensure that you have registered at our website, which is on the page, in order to stay informed of upcoming sessions and events. And on behalf of the GBS-CIDP Foundation's patients and families, thank you, Dr. Massie, for today's session and for your support to our patient group.
It was a pleasure. Thank you for the invitation.
So much.
Take care.
Thank you.
Okay, thank you.